how you doing? Okay, great. So we'll just go ahead and start if that's okay. And we'll just share some great news about your publication, which is actually not so great news, but congratulations that this is research that deserves to be heard. So Dr. Marina Reutemann, my colleague from UCSF Fresno, hepatologist, and also, is it president-elect of the Fresno Madera Medical Society? Did I get that right? Or, oh, that's great. That's fantastic. She has actually just been published in one of our peer-reviewed journals, the Journal of Clinical Gastroenterology. So Dr. Reutemann has messaged about this before, in fact, very early on during the pandemic. She and her colleagues were really quite concerned about how much the alcohol use and its complications were really increasing throughout the pandemic. And here they've been able to publish a paper about this very concerning trend. I think everyone deserves to hear this. I think this very much aligns with the things that we're seeing in the substance use world with other drugs. But if you could just set the context and the background for this and then discuss the significance of these findings.
Absolutely. Thank you, Dr. Vohra, for letting me speak at this forum. I think this is such an important topic. So, when we fast forward back to the beginning of the pandemic, very quickly after the beginning of the pandemic, we noticed a rapid increase in patients presenting with alcohol-related hepatitis. Alcohol-related hepatitis is different from alcoholic cirrhosis, right? In order to get to alcoholic cirrhosis, it takes years and decades of drinking. Your liver becomes small and shrunken. You develop all the complications associated with ascites. So we're very familiar with alcoholic cirrhosis. However, in the setting of alcoholic hepatitis, the time frames are very different. Alcoholic hepatitis can happen, within days or weeks of really excessive alcohol intake. It instead of the liver becoming small and shrunken, liver becomes large and swollen, but it can present with very similar complications to alcoholic cirrhosis, including acute liver failure and death. So while in the past, prior to the COVID-19 pandemic, alcohol-related hepatitis was rare. It was so rare that when we would see the patient, I would take all my learners and we would go and make rounds on this patient. I said, see, this is really rare. You need to know this. And suddenly half of our service had acute alcoholic hepatitis. So this is what prompted our initial research effort and studies. And from the bird's eye view, we have looked at CMC at 3 institutions, including Community Regional Medical Center, Clovis Community, as well as the Fresno Heart Hospital. And we compared the patient admissions with acute alcoholic hepatitis prior to pandemic, as well as during, in the early phase of the pandemic. What we found was quite staggering, and it really supported what we were seeing clinically. We saw a 51% increase in overall incidence of alcohol-related hepatitis. We saw a 94% increase in rehospitalizations. These patients were sicker. They were coming back because they were not able to successfully function in the community. We saw a 100% increase in patients under the age of 40. These are really staggering increases, as well as a trend towards a very significant increase, 125% increase in women. So these were really staggering numbers. The part of the reason I'm happy to talk to you about this now is we're now entering the 3rd year of pandemic. So whatever bad habits have started in the beginning of the pandemic, they have been firmly ingrained into our society. And I have no doubt that the pandemic within the pandemic is only going to continue. And we really need to pay attention to our patients with alcohol misuse disorders and really come up with a public health intervention that can combat this pandemic. We are looking preliminarily at the data in the latter part of the pandemic. And again, it mirrors very much our clinical observation that this is far, far, far from over, and this is going to have years and decades of consequences. Thank you.
Thank you. That's, you're presenting some stunning numbers. And there's so much that we can talk about here. I think a lot of people might be wondering, in general practice or even in the emergency urgent care side, what actually works whenever we know everyone's time is very brief in terms of the clinical encounter. What can be done in that brief time? I mean, do you support, like, I remember reading about medications like disulfiram way back when I was in medical school. Is that the right guidance right now, or are there other best practices that we can be all implementing?
This is a great question, Dr. Vohra, and I have really been trying to understand more about it, and specifically more about it in the setting of chronic liver disease. The disulfiram anti-abuse is contraindicated in patients with chronic liver disease, so this is not going to be a good choice for us. One of the medications that I have recently been reading more about is gabapentin or Neurontin. It's quite a benign medication. And from my research, I understand that it works very well for patients with alcohol withdrawal, and it can be used in patients with underlying chronic liver disease. So personally, I'm going to try to use that. This is going to be a new avenue for me to explore. And but even just taking, a bunch of steps back, I think just asking the patients about patterns of their alcohol use, something as simple as a cage questionnaire can be very effective and can catch patients from going down that cliff from before they get into difficulties.
Yeah, I think that's huge. I mean, that's like a no-cost intervention. It takes very little time. And, as someone who really looks at the neurotransmitter aspect of it, I think that's kind of what excites me about toxicology. Every time you make a good connection with the patient, you're actually activating those reward circuits. And as long as there's not drugs involved, those reward circuits are actually, good. So anytime you have a good empathetic conversation with the patient and you let them know that you're there for them, that that you understand what they're going through, and that you might be a partner in helping them find coping strategies that are not related to substances. That's all serotonin and dopamine. That actually works. It takes time and it takes practice and skill, but it's low cost. Very few side effects from just having a benign conversation like that. And if it keeps somebody from going into, the complications of alcoholism that Dr. Roitman is describing, then that's all the better. So that's kind of the harm reduction strategy that we definitely try to employ with other drugs of abuse, but it seems like it would also work with really our approach to alcoholism is just have the conversation. This is worth it. This is really stunning. I mean, aside from all of the COVID deaths, there's a lot of non-COVID deaths from this pandemic that we're still trying to understand. And Dr. Roitman's really great research is showing the path forward in terms of exploring all of the ramifications of this pandemic. Congratulations. I mean, I know it wasn't easy to do research during this pandemic. I really want to commend you for getting this study published. Are there any questions about this study or just in general for Dr. Roitman about alcohol use and liver disease?
Thank you, Dr. Vohra. I see the question in the chat. Is there a specific dose for gabapentin that we should use? So, take it with a grain of salt. I have not started using it. I am just reading about it. But the recommendations generally are to start with a low dose, about 300 milligrams at night. And you can ramp it up pretty quickly. You can go to 300 twice a day, 300 3 times a day, and then increase it to about 1,800 milligrams a day. So that's the recommendations that I have been reading.
Yeah, that's my practice also. 100 TID or, some combination of that. I think that that's a good initial dose. And it's a mild anxiolytic that, might help people from reaching for either alcohol or other drugs, and is really relatively well tolerated even with liver and renal disease.
Exactly. Well, thank you so much for having me, and
Yes.
I will keep you updated on the follow-up.
Thank you so much. Yeah, we appreciate you, and thanks so much for stopping by to discuss this research.
Thank you.
Great. I'm gonna go ahead and share another document just to talk about COVID updates, and so we'll dive right into our COVID metrics and other updates here. So again, we'll hyperlink to the study from the Journal of Clinical Gastroenterology that Dr. Roitman just cited, and we'll add that to our notes as well. In terms of our COVID metrics, the news is bleak. We already predicted at the outset that January was going to be bad, and it's actually exactly what's happening. Just in terms of the whole valley, so these are all of the counties in the Central Valley. All of us have a collective R of greater than 1.75 or around 1.75. And really the whole state, there's really no county, no region that's under 1 at this point. So the whole state is still experiencing this really exponential spread of COVID throughout. And that's really burdening our hospitals. We're now starting to see this uptick in the hospitalization number. There's 373 positive patients in all of our county hospitals and 60 ICU patients. You might think, oh, well, this is just kind of like the Delta surge and it's really not as bad as last winter's surge, but don't get fooled. This thing is going to be very, very challenging. And here's what the forecasts are showing. I mean, this is so stunning. I almost don't believe it. And I really hope that all those epi nerds at the state are wrong, but they're never wrong. And that's the problem. So here's basically what has been going on with our county. The dashed line is basically today, and here's what they forecast will happen. So basically, they've had to change the magnitude of the graph on the forecast, because what they're saying is right now we're in the mid 300s. We're probably going to go up to 1,200 hospitalizations by the first week of February. Like I said, when I saw this, I had to blink and look twice because I almost didn't believe it, but that's what they're saying. We're at about 50, we're about at 70 ICU beds. I pulled this yesterday, but they're saying we're going to have almost 300 ICU patients by the first week of February. And keep in mind, our county has only about 190 ICU beds. So I don't even know where we're going to put these ICU patients. So this is very, very concerning. Now, again, predictions are predictions. These forecasts might change, and we sure hope that they do. But right now, this is what we need to be preparing for, is not only a gradual rise throughout January, but something, I don't even know how they're generating this curve, but something is really going to just cause a steep rise at the end of January. So just brace yourself that might actually happen. And I'm watching this very closely every day. I was like, is this just Fresno? Are they picking on Fresno? So then I took out Los Angeles, and same thing. LA is destined to have 40,000 hospitalized patients by early February. I mean, that's just unthinkable numbers. And like I said, it just dwarfs anything that happened with the Delta wave or even last winter's surge. And we sure are hoping that these predictions are somehow off, but that's exactly why everyone is so worried about this Omicron surge. I know I'm preaching to the choir, and all of our healthcare community understands just what we're in for. I don't think the general public is necessarily quite as alarmed. And so that's why I want to share these numbers, because if you have these conversations with your patients and your staff and the general public, let them know that, the best epidemiologists that are working on this are predicting severe pain for the end of January and early February. In terms of self-test kits, these have not yet arrived into the county for the general public. As soon as they do, we're going to activate this website that we showed you last week. So please have your patients check back here and let them know that that's where they can order self-test kits if they are in one of these zip codes. which is really one of the zip codes that is considered kind of lower socioeconomic status, vulnerable populations, according to the Healthy Places Index. This is not the only way people can get home test kits. If they work in the restaurant industry, we're working with the Restaurant Association. If they are a family that has a complicated, a medically complicated child, then we want those families to be fully protected as well. So we're working with that pool of people as well. But you know, test kits are going to be very short, unfortunately, until and unless the state or the federal government figure out some other way to distribute test kits. For medical offices and healthcare providers, you can actually go through the Mohawk and get test kits that way. So Curtis Jack with our Mohawk has been elevating these requests to the state. And here's the email that you can use. It's just mohawk@fresnocountyca.gov. So please, if you need them for your clinic, these are the test kits that you should be ordering or requesting, and we'll try to fulfill those requests as best as we can. And remember, OptumServe is still around, and there's lots of pharmacies that are doing testing. I know that the testing lines are longer and longer, and the turnaround times are longer and longer. However, there's still thousands and thousands of tests that are available throughout the county. And in fact, OptumServe is really trying to expand in our county to offer more lanes, more days, more staff to keep that keep that volume as high as we can, because we know a lot of people are relying on those kinds of tests. In terms of national news and updates, there's several things that have happened this week. So I just highlighted the major ones. First, the CDC has come out with a couple of different pronouncements related to immunocompromised people. First of all, you know, if you're immunocompromised, you really should be getting about 4 shots right now. You should be getting 3 mRNA shots, which is your primary series, and then a 4th shot, which is the booster, 5 months after your primary series is over. So that's where the 4th shot comes from. The language is all screwed up, but they don't even want to call it a booster when it's your 3rd shot. They just call it part of your primary series. But just keep in mind that, you know, whenever we talk about 4th shot, it's really only approved for immunocompromised right now. I've gotten a lot of questions about, well, what if you're not immunocompromised? Can you still go ahead and get a 4th shot? And right now, the CDC has not recommended that for kind of your non-immunocompromised people. They say that if you're boosted, you're protected. And that actually is true, just based on the data that the state is sharing, is that even though the protection wanes a little bit, it's still much better if you're boosted in terms of taking on this Omicron infection. So that's one thing. I know that it's confusing, and I'm going to talk a little bit more about something else that's there for immunocompromised patients called Evusheld in a little bit. But remember, I mean, these are the people that we really got to protect against Omicron, is the people that are not going to be able to launch a really good immune reaction on their own accord because they're transplant patients, because they're on steroids, they have some kind of autoimmune disorder. Those are the folks that are guaranteed to land in the hospital in the ICU. So we really have to, I think, work extra hard to make sure that they get those shots and work with them to get something called Evusheld, which is a long-acting monoclonal antibody that they can get prophylactically. So I'll talk more about Evusheld and how we plan to roll that out in a little bit. Next, another kind of myth busting that I think we need to do is to say kids are not necessarily going to be, slide through this. Our children's hospital is kind of filling up. And nationwide, the children's hospitals are not just filling up, but they're kind of like, overflowing at the seams. So kids are being hospitalized at very high rates. Some of them have COVID as an incidental finding, and many do not. And so I think that needs to be kind of appreciated, something that we're trying to get more data around here in our county and in the Central Valley. But really, it's just another reason to get everyone over age 5 vaccinated, because I think we hear a lot of discourse that says, oh, kids are going to be fine. We don't necessarily need to vaccinate them, et cetera, et cetera. And I disagree. I think anyone over age 5 should be vaccinated to protect them and also protect all of the vulnerable kids out there, by way of herd immunity. Next, you're probably very well aware of this, but this is getting national attention, and that is the short staffing related to hospitals, long-term care facilities, and other clinics, to the point where now organizations are actually considering or moving forward with the very hard contingency that the CDC has spelled out about allowing people that are COVID positive to skip all quarantine and isolation and just come right back to work as long as they're asymptomatic or mildly symptomatic. So that's not a step that anyone wants to take, but in the real world, just to keep operations going, that is a step that many organizations might have to take. So you'll be hearing more about that. We're working with our hospitals to really dialogue about how to do that safely. And I'm sure that if you're at one of the hospitals, you're having multiple meetings about how to make this happen and do it as safely as possible. But it's just another sign that, we're in just a thick of a really bad surge. And it's something that insofar as we can have a consistent approach countywide, I think that will make everyone feel better. And that will set patient expectations that, if you go to a hospital today or next week, just depending on when things happen, that you might be taken care of by someone who's COVID positive, because there's really no one else to take care of you. And that's just something that you can expect. And as long as people are wearing masks, that we can mitigate that risk as much as possible during this time of severe critical staffing shortages. So that's something that, again, I don't want to belabor it today, but just something that's out there. And CDPH has put out some guidance about how to make that happen in their quarantine and isolation guidance for healthcare workers, which I shared with you last week. And this is something that actually people are now starting to pull the trigger and move towards. We're also doing the assess and refer policy on the EMS side. So that's something that we've done multiple times. And this was activated, I think, yesterday. And Dan Lynch announced that on our media. So it's out there in the public. And that means that when 911 is activated, that patients that are otherwise stable and deemed not to have an emergency condition are not necessarily going to be transported, and that they may be asked to visit their primary care doctor or do telemedicine or wait to go in another day if they're stable enough to wait. So that's called the assess and refer policy. That means you're not going to have automatic transport of every single 911 call. Lastly, I just found out about this about an hour ago, and that is a Supreme Court decision. So I consider this like you win some, you lose some. So the Supreme Court decision was looking at vaccine and testing mandates. And they basically said that for non-medical employers, they're actually not going, they basically blocked the vaccine and testing mandate that the federal government had put into place. However, they upheld the healthcare worker vaccine mandate. That's my very early reading of the headlines. I didn't have time to do a deep dive because this just happened like an hour ago. So you may actually have even more information than I do at this point, but that's out there also. Let me tell you, the water is so cloudy right now because Cal OSHA is weighing in on this, CDPH is weighing in on this, and now the Supreme Court is weighing in on this. It's kind of a hot button issue. We're having a lot of conversations just regarding outbreaks and outbreak management here in Fresno County related to who we can test and who we can't test outside of the healthcare sector. So this just adds more kind of fuel to the already burning dumpster fire. That's all I'm going to say about that. Let me switch gears. Let me just see if there's any questions so far. And then I'm really going to do a quick review about medications and some of the updates that we have about medications. Please unmute yourself if you have any questions. In the meantime, I'm going to go through the chat questions real quick. All right, for Farishta, if the health department's doing testing and where, so that's going to be on the testing website. And Sam, if you could drop the website for all of the testing that's going on around the county. Oh, there you go. So that's basically where you can get the best information about where testing is available. And then obviously, if you need home test kits for your clinical staff, you can email the Mohawk. And if you're getting questions from patients about home test kits, then those have not yet arrived to the county. We were really hoping it was going to happen this week, so we're expecting it to. We think that there's a truck somewhere on the 99 that's coming into the county like as we speak. And as soon as it arrives, we're going to do a press release and let people know that they can sign up on that website that I shared with you to get tests delivered to their house. It's basically like a mini Amazon program that we have, and people can actually ask for, I think, up to 8 kits per family per week delivered to their house. All right, someone's saying, CDPH is saying that there's no time frame when a booster is given and that there's no need to wait 14 days. What's the call on Fresno County? Wait 14 days or no need to wait? I'm assuming you're asking about if someone's considered up to date with their vaccinations. And we really just align ourselves with CDPH as much as possible to avoid confusion. And so that's probably, if you see that in writing by CDPH, we're not going to be more restrictive on that. However, stepping away from that and just looking at it scientifically, just know that boosters don't fully mature until 14 days have passed. So clinically speaking, you know, it just depends, like, are you asking, you know, from a legal standpoint, which is what the CDPH says on paper, or from a medical scientific standpoint, which is, you know, that would make you lean more towards 14 days for most people, and know that that's an average. Some people will take longer, some people will take less time, but that's usually an average of 2 weeks for any vaccination, whether it's COVID or influenza or whatnot, to really launch a mature immune response. All right, Kelly, I hope I answered your question. We're hoping imminently for when those tests will arrive. Lance just wants a current vaccine. So do I, Lance. I hope that they come up with one. It's, you know, again, I know it's very disheartening to see all these breakthrough infections, but, you know, we're not really seeing a lot of breakthrough, like severe infections that lead to hospitalization and ICU visits for the most part. So knock on wood, you know, the boosters are still helping. I mean, imagine if we didn't have vaccines or boosters at all, I think we would be in a lot worse condition. So for what it's worth, even though they're not perfect, no layer of protection is perfect. They're still doing, they are still helping. Okay, and then the Pregnancy Care Center is asking if the Fresno County Department of Public Health adopted the newest guideline for screening and returning to work in a healthcare setting. Yeah, I mean, we're up to date with CDPH, so I'm not sure what the date was, whether it was December or early January, because there's been so many updates to all these different guidelines, but there is a quarantine and isolation guideline that has been kind of refined by CDPH. And so you should look at the latest guideline, which also contains an FAQ, and then just follow that. What we're actually doing is taking down slowly our local orders that we had, which is a process called rescission. So we're going to actually be doing rescission of all of our local orders, and then basically just saying we're going to revert to the state's orders for almost everything. And then that way there's not a lot of confusion, because honestly, the state does not give us any notice at all whenever they change things. And so we know that that catches people off guard. And so we're basically going to go with the state unless there's an extraordinary reason why we would divert. And Chris is sharing that the Sunday New York Times had a great article about hospitalizations and infections and deaths, which you can refer to on the, I guess it's the Sunday New York Times. All right, thank you for all those great suggestions. I really appreciate how we all work together to share information. We definitely appreciate hearing from you, and we definitely want to hear if you have questions. Anybody want to unmute and ask any questions before we move on?
I have a quick question.
Sure, go ahead. Go ahead.
Do you anticipate restrictions on the size of gatherings coming out in the next few weeks? I have a selfish reason for asking because we're planning a conference.
Not like small gatherings. If your gathering is like greater than, I think, 1,000, then I think that there are already some restrictions there. Like you have to ask for proof of vaccination and or a negative rapid test. So that's called like a mega event. And those gathering restrictions were put into place even for the Delta surge. and they haven't made them more or less restrictive for this Omicron surge. For smaller gatherings, there's really not a lot of restrictions, but there's the understanding that people will just make their own risk-benefit calculation, and if they choose to have gatherings, that they will do it with everyone boosted or ask people to test negative.
Got it. The reason I ask is that Sonoma County has issued a ban on large gatherings greater than 50 people. So I was just wondering if there's a thought
interesting.
of more of that coming.
We have not had any conversations about doing that. So I'm not sure. Some of the discourse about this surge says that, it may actually just be over as soon as it started, which means that, we may be done with it and on the downslope by mid-February. So there's a lot riding on that. I think that's really based on the South African experience, and that really has not yet been replicated anywhere else. And so I think other countries will have to demonstrate that actually does happen, that you go through 4 to 6 weeks of hell and then it's over. But it's like, aside from that, even if that happens in California, I don't know, something tells me that it's not quite going to happen that way in the Central Valley, because that's what happened with the Delta surge. Is the Delta surge really went down everywhere else, but in the Central Valley, and like our county, Tulare County, Merced, like we never quite went all the way down. We just kind of plateaued. So that's what really scares me, is that our numbers will go really, really high, and then even when other parts of the state are coming down, we won't come down as fast. So it's just hard to predict where this will all take us. It really is hard to predict. Do I foresee schools going back online? So yeah, that's a good question. There's a lot of cases in the schools, and basically we are just going, we're really calibrating, almost to an individual level to say, we'll work with the school. We'll figure out if there's a child that's affected, then they need to isolate. If there's more than one child that's affected, like 2 or 3, then we're really going to strongly consider closing down the classroom and really just asking all those kids to stay home for 5 days and then come back with an entry test, basically. We're really not looking at closing down a whole entire school unless there's some extraordinary condition where half the staff gets sick. That happens with norovirus. That's the last time we had to close down a whole school before COVID, was when like half the school basically just came down with severe gastroenteritis, and then you basically just have to close it down. We try not to do that because we know that school is so beneficial in so many other ways. And so that's really been the strategy really at the state and national level. And here locally, that's what all the superintendents really want to do, is they want to support parents, support families, and support their staff with lots of testing, obviously getting people vaccinated and boosted, but they really don't foresee doing like remote Zoom school as a universal measure, just because it's kind of indefinite. Once you start that, when do you ever stop? And so it just seems like it seems like a solution, but it actually creates a lot more problems. I know that that's not a very satisfying answer if you're a parent, but that's kind of what the conversation has been. And Dr. Zweifler knows more about this than anybody, and if he's on, he can share his thoughts about it. But he daily just like works so closely with the schools and basically really tries to support every single outbreak that they're dealing with. Someone's asking, when is the rescission of the health officer orders planned? Yeah, good question. We don't really have a date set. We really want to make sure that we have a lot of our guidance ready to go, in terms of, it's not just the order that you see online, it's also just a bunch of letters and a bunch of instructions to patients that have hyperlinks to our order. So we have to do it all in a coordinated way. So that might take us this weekend. And hopefully as early as next week, we'll probably do a rescission. A lot of other counties have already done it, so it's not like we're going to be going rogue and doing this. And I think it's the right step to take, given that CDPH is moving so quickly, and it just doesn't really pay off for us to try to reinvent CDPH's orders and then have to change them every time they do. Naomi's asking, we have a patient with COVID who then received 2 vaccines, is now due for their booster, but then caught COVID again a couple of weeks ago. When can they get their booster? So as soon as they're recovered, they can actually get their booster. So, they may not have to do the testing for about 90 days after their infection recovery, but they're eligible for a booster as soon as they're recovered. And I would recommend that they get it, as early as they can after they're asymptomatic. All right, let me share another document. And this is going to be really the latest draft of a document that you've all seen before. And this relates to just really all the therapies that we have. So the good news is, among all this bleak news, there's actually a lot of medications that have been developed. The bad news is there's just not very many of them. So they're just coming in as a trickle, a very slow trickle, but we want to kind of share how we should all be thinking about using these medications. And so I'm going to share a document that goes through all of them. A lot of this is going to be review for you because you've heard me say this before, but I also want to share some updates just because these things change quite frequently and we want to make sure everyone's on the same page. Okay, so this says COVID therapies. It's going to start by talking about monoclonal antibodies and then go into some of the orals and then something called Evusheld. So the monoclonal antibodies are what we've had, for a long time. Remdesivir is not an antibody, but it's kind of in this same bucket. And right now with Omicron dominant, we really need to be thinking about only two medications, sotrovimab and remdesivir, that can be used as outpatient infusions for people that have COVID. And they have mild infection or early infection. They don't need to be hospitalized. Their O2 sats are over 94%. They're ambulatory, but they're high risk. So that's the patient who really needs to get monoclonal antibodies or remdesivir. So it turns out that the only monoclonal antibody that's really going to work against Omicron very well is sotrovimab. And sotrovimab, all of our antibody providing clinics are requesting sotrovimab, and the state is fulfilling about 10% of those requests. So on average, we request about 900 doses every week. The state gives us 90. So it's very short. And that's just because the supply is that short all over the country. So if you're having trouble finding someone to give sotrovimab, it's because we just don't get a lot of allocation. However, we need to use those 90 doses as wisely as possible, and we need to allocate them as rationally as we can. Now, it turns out that we have a lot of providers that want to give sotrovimab, and we're actually going to need to convert all these folks over into a new inventory keeping system called HPOP. And I'll talk more about HPOP later, but just keep in mind, if you're on this call right now and you're giving sotrovimab, you're going to have to make some changes to your process that may or may not be worth your time. We understand that you have a lot of other stuff going on. You may actually have staff that are affected and quarantined. If you really just want to drop out right now, just let us know, because then we can allocate your doses to someone else. And right now that's going to be okay, because we don't actually have that many doses to give. So hopefully that makes sense. For those of you who can do remdesivir, I would encourage you to do it. I know it's a pain in the butt because it's a 3-day infusion. And if you can do it, we definitely commend you. The good news is there's lots of remdesivir out there. So this would actually help us quite a bit, is if we had a couple of clinics that were able to do remdesivir infusions, because we think that the supply of remdesivir is actually pretty good. And you can actually just order it yourself. You don't have to go through the county in order to get your supply line of remdesivir. It is something that you have to pay for, or the insurance has to pay for. So it's not something that's going to come as a freebie the way sotrovimab does, but don't let that be a barrier. If the finances are a barrier, just because you don't want to play the insurance game or, pass the charges on to your patients, we totally want to support you. We basically want to make this as easy as possible. So if you want to do remdesivir and you have the staff and the logistical capability to do 3-day infusions, then we don't want the finances to be a barrier. Please reach out to us and we will work with you to make sure that you're successful in that program. All right, so that's monoclonal antibodies. Look for an update from Dr. Zweifler, and also a request to help us get you into the HPOP software, which means that we need certain information from you. And if you are a monoclonal antibody provider or want to become one, we'll reach out to you and share more in a separate email and advisory. Okay, let's move on to oral antiviral agents. So you've heard about these two. They're called Paxlovid and Molnupiravir. One is from Pfizer, one is from Merck, and they're both oral agents. They basically are 3-day pill regimens, and you can give them to people that are immunocompromised, incompletely vaccinated and elderly, or they just have risk factors that puts them at high risk of getting hospitalized. So kind of the same population that you would give monoclonals to, except this is even more convenient because they just show up to a pharmacy with the prescription and the pharmacy gives them their 3 days of pills. Sounds easy, right? The problem is there's not a lot of these either. So there's only about 2,000 of these coming into the county, 2,000 doses that is. And that means there's about 200 doses of Paxlovid and the rest of them about 800 to 1,500 of Molnupiravir coming in every week. And here's the pharmacies that have them. You've seen this list before also. We have not been told that that this list is expanded for our counties. So just keep in mind that there's only 4 pharmacies in Fresno County and about 10 pharmacies that provide Molnupiravir and 4 that provide Paxlovid. And they have very few allocations. They each have about 40 doses on average per week. So that basically is a very small supply compared to the demand. But that's kind of where things are. Paxlovid has a lot of drug-drug interactions. So you might want to just bookmark this checker. You've heard me say that before. What's really cool is since I've presented this topic before, I've been working with our staff at the Poison Control Center, and they've actually come up with a really cool one-pager that just tells you all about both these medications, comparing and contrasting them, and really all of the details that you need to know, including contraindications and drug-drug interactions. And it has that same checker website. And this is just a one-pager that you can post or circulate among your staff, et cetera. So we will push this out as part of our next advisory on oral antivirals. There was also a CDC call that I think that we shared information about yesterday with you. And that CDC call was really just detailing everything that's on this page. So if you want a longer version of this Cliff's Notes, then you can go back and find that CDC call, and they will archive that webinar, and they usually do a really good job transcribing all of the information that was shared. And whenever I come across that and track that down, I will hyperlink there too. So lots of information coming out about this. The supplies are really low, but this is really the future. This is basically going to become almost like a Z-Pack for COVID. And when people have high risk COVID, or they just come down and they get really, worried that they're going to get hospitalized, et cetera. I think that this is really going to be, if not these medications themselves, then this model where you basically just write a 3-day prescription and you just say, here you go, and go to your pharmacy and go pick this up. This is where it's going to go. So that's why it's I know as impatient as people are to get through COVID and to try to get to, the endemic stage of COVID, I'm the longer we wait, the more these medications are really going to get developed and refined. And some smart company is going to come out with medications that don't have so many drug-drug interactions, et cetera. And then COVID will really be something that's very well managed, the way that we manage sore throats from bacterial infections, et cetera. So that's kind of what I see as the future of COVID treatment. Again, I don't have a crystal ball, but that's kind of where things are going, just the way things are being developed. The last thing that you need to know about is something called Evusheld. This is a set of 2 different monoclonal antibodies that you can actually give beforehand. So it's pre-exposure prophylaxis. Pre-exposure prophylaxis that lasts for 6 months. So this is another cool agent. It's reserved for people that are immunocompromised. So again, it's basically age 12 and older, weighing at least 40 kilograms, moderate to severe compromised immune systems due to a medical condition or medications, and may not mount an adequate immune response. Or if they're basically allergic, they have severe adverse reaction to the vaccine, or they have some other reason why a vaccine is not recommended, then Evusheld might be a good answer for them, where it really protects them for 6 months against really the bad complications of catching COVID. So how do you get Evusheld? Well, again, the feds and the state is only giving us about 250 doses of this, and we really need to make sure it goes to that very vulnerable immunocompromised population. Now, Evusheld is being shipped to 2 of our local hospitals, CRMC and St. Agnes. It turns out that because of logistical and clinical constraints, they don't really have a good way to distribute and administer this. So what they're going to do is pass it on to our partners in the outpatient setting. And those partners in the outpatient setting are going to be distributing and administering the Evusheld onto the patients. So it's kind of a 1-2 reaction. The hospitals will receive it from the state, and then they will redistribute. And then once they redistribute, then the patients can go to these outpatient centers and then get the Evusheld administered. And it's just a single injection, so it should be a quick visit, and lots of information on the FDA fact sheet about other fine details of indications, contraindications, et cetera. So that's basically how we're going to do Evusheld. If you're interested in being a site that administers this, because you see a lot of hem-onc patients, or you see a lot of transplant patients, or you have other immunocompromised patients in your practice, then reach out to us or reach out to these hospitals. I've got their emails here, and I've taken the liberty of nominating Amy and Paul from CRMC and St. Agnes to be the point people for the clinics. Please don't send patients to email them. That's really not appropriate. We're going to set up more advisories about how patients can find the clinics once we identify the clinics themselves. Now, what does it take to be a clinic that gives Evusheld? Eventually, you're going to have to get into the HPOP system. So this pain in the butt inventory system is really what the state wants done for monoclonals as well as Evusheld. And so that's basically, you have to get registered into HPOP in order to become a distributing site. Right now, we're allowing people to do it without HPOP, but very soon it's going to become a requirement. So what does HPOP require? Well, basically, this is all you need to do. You're going to need to send all of this information to Curtis Jack. Excuse me. So your name or your clinic's name, address, city, zip, county, a contact email, and a contact name and number. Then you will be given like an HPOP provider number and an HPOP PIN. And then we also want to know, do you accept walk-in and same-day appointments? Do you accept certain insurance and non-insured patients? Do you serve a vulnerable population, and what kind of vulnerable population? Is there a copay or additional cost? And do you have refrigeration? We're trying to filter people out so that we're not wasting each other's time, and really identify partners that we know are going to succeed with this program, given the kind of rigorous requirements that the state has about serving vulnerable populations. So we're really trying to, identify people that are going to have a high chance of success whenever the state actually implements this HPOP requirement. And we're really just creating the on-ramp to do that. And that's why we want this information earlier rather than later. Again, you're going to see an advisory coming out from our health department about Evusheld, about HPOP, and about the new rules, as it were, for monoclonal antibodies with sotrovimab and remdesivir as the priority focus. And that way, exactly like what to do in this current era of the Omicron surge. And then you'll also see an updated advisory about the oral medications, the Paxlovid and the molnupiravir, with this really cool table that's like a handy guide to both medications. All right, so that's all I know about the medication side. Let's hear your questions and any other commentary from our partners at the health department.
Dr. Vohra, this is Dr. Baz. Can I ask a question?
Yes, sir, go ahead.
Sorry, I missed some of the talk, but seeing patient running back and forth. Evusheld, we have got a lot of immunodeficiency patients. And of course, we are worried about it. At some time, I'm giving them other monoclonal antibodies. So we definitely like to give it to that. So who do we need to approach, and how do we want to get it?
Thank you,
I
Dr.
get
Baz.
daily that calls.
Yes, thank you. We will work with you. If you or someone at your clinic can email us, you can please just email Curtis Jack if you want to directly with this information, or you could just email myself or Sim, whatever's more convenient for you. And we will reach out to you and your staff to make sure that you become an Evusheld provider if you have a patient population that needs to have this Evusheld.
And one more question. I just barely heard you about Paxlovid. I was just walking in. Sorry I know this information was given. Is Paxlovid available right now if we want to prescribe?
Very limited supplies. There's only about 160 doses coming into the county every week. So that's about 40 doses at pharmacy. And here's the 4 pharmacies that are listed here. There's 1 CVS and 3 Rite Aids. So that's why it's very hard to get. And you really have to tell your patients, I'm going to write a prescription, but you may not be able to get it just because they're going to be running out. And unfortunately, that's the reality that we have to tell all of our patients right now.
And my last question, I personally am very comfortable with the Remdesivir, and I think it's a great medicine as an outpatient. Are we allowed to give those medicine as outpatient? And if we,
yes, sir. The Remdesivir now is now indicated as an outpatient infusion. You do have to do a 3-day infusion, and that's detailed right here in this box.
Right.
Number 2. So if you want to do that, that would be wonderful.
All
so,
right.
Or it wasn't allowed for outpatients, but now it is. And now that, you know, we're short on everything else, it seems like an attractive option if you have the capacity to do the 3-day infusion.
I'm willing to do on the limited number of patients, but I can handle it, and I'm comfortable giving, and I'm not worried about the reaction. So if we want to get hold of free Remdesivir, we have to go through county or through the pharmacy?
No, sir, you can order it yourself. We can certainly walk you through it, or if somebody else on this call knows how to order it. But basically, I've been told that AmerisourceBergen is the vendor, and you just order it through them. And, you know, as long as you have a vendor pipeline, that you can actually order it like you do all of your other medications.
Thank you very much. It's always very informative, your meeting. And sorry, I just have to run in and out all the time.
Oh, no, God bless you for doing all that you do. We really appreciate you.
Thank you.
Dr. Baz. All right, any other questions? I'm gonna go back to the chat and see. It looks like Dr. Naz has posted that St. Agnes is administering Evusheld. So thank you very much for doing that. And like I said, we're gonna put out an advisory, and hopefully in the same way that we've generated a really nice list of monoclonal providers, we wanna do the same thing with Evusheld providers. So just keep in mind that that's our vision is, you know, hopefully in the next week, we will have, you know, a list of hopefully a handful of clinics that will provide Evusheld. It's just, if you want to be one of those clinics, you need to have refrigeration, you need to have cold chain transport and go pick up from CRMC or St. Agnes, and you need to have daily reporting and really tight communication, because that HPOP has to be kept up to date. Otherwise, you know, the state will just cut us off, unfortunately. Is if we don't keep our inventory up to date, the state will assume we're not using it, and then they'll allocate less next time. So that's why we just have to make sure that we keep doing that. All right, what else? I see Chris is on. You know, we continue to have a very severe blood shortage. And I know that he wants me to tell you that we need blood donors. So please keep that in mind. If you yourself can do it, if your staff can do it, and you can kind of motivate and cheerlead your staff into doing a blood drive or donating at the lovely facilities that the Central California Blood Center has over on Herndon, then I know that will be much appreciated. It is being used, you know, all of the blood is being used at all of the hospitals. And so we need to keep that pipeline going so that we have that life-saving resource. Any other questions? All right, I know that's a lot to crunch through. I'll definitely share out these notes. And like I said, you're going to be getting a lot of advisories this week. So check your email and try to go through that information if it applies to your practice. And if you have any other questions or concerns, please reach out to us. We really appreciate everything that you're doing. I know that January is very challenging. Next week and the week after that, I guarantee, are going to be some of the hardest of the pandemic. So please pace yourself, take care of yourself. Be patient as these crises come up. It's a really hard time, and we just need to give ourselves the space and the peace of mind to try to get through it together. I really appreciate all of you. Thank you.
Thank you.
Thank you.